Welcome to the American Academy of Emergency Medicine's Justice, Equity, Diversity, and Inclusion section webinar, Language Justice in the ED. My name is Kristen Fontes. My pronouns are she, her, and I will be your moderator for tonight's session. For anyone that's joining us live, please feel free to say hello, introduce yourself in the chat. We'd love to greet you. Tonight's session will also be recorded and uploaded to the JEDI-AAEM website within 48 hours, so it can be viewed later on. These sessions are meant to be interactive, as I've said many times before. So for anyone who's joining us live, please feel free to use the chat to ask questions. We'll do our best to incorporate them throughout the night. Please know this is a safe space as well. We really encourage and welcome any participation from attendees, and we really want to foster open and respectful dialogue because we're talking about issues that affect marginalized groups, whether that's patients or healthcare workers. I always just like to include a content warning that sometimes the content could be triggering or upsetting for some folks. So if you do find yourself in that position, please do what you need to do to take care of yourself, even if that means stepping away from the conversation here. We are here for you as well, so please reach out if we can do anything to support you. Okay, so I would like to now transition to introducing our panelists. So you can go ahead and come on screen. And we will start with Dr. Sophia Simic.
Hi, so my name is Sophia Simic. I am an emergency physician. I'm originally from Lima, Peru, and I grew up kind of all over the world. I moved around a lot, lived in Venezuela for some time, and mostly grew up in Puerto Rico, where I went to undergrad. I went to the University of Puerto Rico for medical school before moving to the Bronx to do residency at Jacobi and Montefiore until 2018, and spend the last 4.5 years at Jacobi as an attending. I graduated 4.5 years ago and stayed there as an attending, and currently am taking some time off, like a bit of a sabbatical. And yeah, my interests are international medicine and women plus in emergency medicine.
Great, thank you. We'll move on to Dr. Elaine Rodriguez.
Hi, my name is Elaine Rodriguez. I am Dominican, raised in the Bronx. Went to residency, also Jacobi and Monte, from where I am now, which is Staten Island University Hospital. They're an attending physician, and then I'm also the director of community outreach and also the D&I person for my department.
Excellent, thank you. And finally, we have Mr. Amado Estrada.
Hello, everybody. My name is Amado. I was born in Cuba, and I fall in love with emergency since I was in middle school. Then moved to the States. I finished my undergrads in Florida State University, then went still in my 4th year of medical school at St. George's University. Right now, finishing my elective rotation at Wyckoff Medical High Centers in Brooklyn. I also like to teach Spanish. I have taught some courses to introductory medical Spanish to residents and students. And I like numismatic. It's just collection of like paper, money, and coins.
Excellent. Welcome, everyone. So our topic tonight is language justice in the ED. And our discussion is really going to focus on the importance of language justice as a way to reduce health disparities when caring for patients in the ED who have limited English proficiency. Okay, so to do that, we're going to actually start with a patient case presentation. I'm going to go ahead and share my screen in just a sec, and then I will turn it over to our panelists to do the presentation. Okay, so just 1 second.
Okay, so we're gonna start by just talking about a case. Basically, it's very interactive, so please, by all means, just if you have any questions, just stop me. So basically, this is the patient comes in, a 65-year-old male, and this is the triage note, right? The complaint is that he has a headache, he feels lightheaded, his heart rate is 87, his BP is 168/59, the respiratory rate is 16, and the temp is 98. The O2 when patient presented was 100%. So you walk into the room and you see this middle-aged man, kind of just holding his head, but resting on the stretcher. And you just walk into the room. Next slide. And then you kind of start with the history, right? So, when I walk into the room, I'm always like, hi, my name is Dr. Rodriguez. What brings you in today? And then the patient replies,
Hola, doctora. ¿Habla español?
sí, ¿qué vino hoy
Ay,
al hospital?
qué bueno. Tengo mucho dolor de cabeza y mareo desde esta mañana.
Okay, perfecto. So just to stop here, just to bring you back onto what this case was. So the case, when it actually first presented, this is the second visit where the patient actually was able to interact with a clinician that spoke their language. During the first visit, that wasn't the case, but let's see what information we get, right, with using their language. So, señor, ¿me puede decir desde cuándo tiene esos síntomas?
Desde ayer, yo estuve aquí en este hospital ayer y me mandaron para la casa, pero no me siento mejor.
Okay, so usted me dijo a mí que estaba en el hospital ayer. ¿Qué le dieron ayer?
Creo me dieron algo para el mareo, un medicamento, no me acuerdo mucho. Ahí solo ayudó un poco.
Ok, perfecto. Aparte de mareo, ¿tiene algún otro síntoma?
He tenido problemas un poco en caminar, pero eso comenzó hoy.
Ok, perfecto. Cuando dice que tiene problemas con caminar, ¿cómo así exactamente?
Como que me voy para los lados.
Ok. ¿Tiene dolor de pecho? ¿Siente que no puede respirar?
No.
Okay. So just to stop here. So as patient said in Spanish, he actually indicated that he was in the hospital yesterday, and they gave him something for the dizziness. I was actually the person that got this case the second time around. I did a little chart review and noticed that patient was treated as peripheral dizziness, given meclizine, and patient did say right now that he did feel better after the medication, slight better, but now is having difficulty ambulating. Next slide, please. Okay, so I think you picked a little. So we moving on now to like the physical exam, right? So I did a little animation.
I'm
so I don't know
sorry,
if that's,
Elaine.
like,
Oh,
it's
I'm
okay.
sorry. I don't think it's animating here. Do you want me, is there a specific image I should just stop on?
No, I'll just continue talking.
Okay.
So basically, on exam, patient did have an ataxic ache. And when I say ataxic ache, I mean the patient's kind of moving side to side. He was complaining of dizziness. At that point, patient was taken to CAT scans, and then we found. Now you can go through the. We can. Right. So this is basically patient had an ischemic stroke. Unfortunately, in this case, there was a delay in diagnosis. When speaking to the other providers and also doing chart review, it was kind of discussed that patients at the first visit used his daughter as a translator. And there was actually concerns after reviewing the case that there might have been something missed during translation. As the first provider was under the impression that this was not the first time it happened. It's been going on for quite some time. So it brought up a concern, particularly to me, of, are we really, are we really missing an important piece of history with patients when we don't use translators, or sometimes when we use family members as translators, right? Because something that I remember my attending to tell me all the time was that if you listen close enough, the patient will tell you what's wrong and what their diagnosis is. So just to give you a little brief update about what happened to the patient. I mean, I kind of lost track of it, but on the second visit, patient was diagnosed with the cerebral stroke. He was out of window for any intervention at that time because it was over 24 hours. I think at that point he was in 48 hours. He was admitted to the neuro ICU. Patient was later discharged to follow up to rehab, but then I kind of lost track of follow up. Patient never followed up again. But this case actually highlights the importance of speaking the appropriate language for the patient, right? There's been studies that have shown over and over again that people that don't speak English are at a higher risk of having increased morbidity and mortality when they visit our hospitals. And that's something that's extremely sad, right? We have technology, we have the abilities to provide translators for these patients. Sometimes it does take a little bit more effort, and when asking my colleagues, and particularly because I have taken this on in my department, the main concern is that it kind of becomes another step, right, to treating the patient. I have to get the iPad, and if I can't find the language that the patient speaks, because sometimes you do have dialects that are difficult to find, then I can't talk to the patient. And then, what if the internet doesn't work? But just doing that extra step can be life-saving, can be limb and life-saving to a patient, like we saw in this case. And this case is only one of the few that I personally have encountered, and I know that my colleagues have encountered. So patients don't have this is actually amazing. This is actually Sophia that put it in, but Dr. Simic, but basically patients are not the problem, right? The healthcare system is, and it needs to change. The School of Medicine or the House of Medicine has a lot of building to do. Our foundation is very wishy-washy, and it's clear. And we have to do better. And this is definitely an area that we have to work on.
Okay, great. Thank you for that. Sorry about any technical difficulties that we encountered here. All right. So for anyone that is either here with us live or watching this later on, just take a moment, having taken in that case. In particular, the interaction between Dr. Rodriguez and patient Estrada. How was that? I, as someone who understands a little bit of Spanish, but certainly would not consider myself fluent, there were things that I didn't understand. And I think being able to really put yourself in the position of what's it like for the patient when a physician, nurse, other staff member walks into the room speaking English, and the patient actually has another language that they would feel most comfortable using. So it's a great way to, I think, really kind of make the initial impact, is to really see what does that actually look like as an outside observer when you see or you're sort of witness to an interaction that is in a language that you don't primarily speak. So that's, I think, really where we wanted to frame our discussion tonight. Now, I keep bringing up this term language justice, and it's something that you may have heard before. I know there's some talks, I think, that are out there within the EM world. I want to just turn it over to our panelists, and anyone is welcome to speak up. But, what does that term language justice mean to you, or how would you define it? Especially as someone who's a native speaker, what does that kind of mean when it comes to interacting with the healthcare system?
So I can try to answer. For me, language justice in the setting of healthcare is being able to provide appropriate care in all languages. I think ever since the Affordable Care Act, it requires that all facilities that receive some type of federal funds have some type of qualified interpretation available. I know when I went to residency and when I worked at Jacobi, we always had it. It was a phone number you'd call. So for me, language justice is being able to provide the same care to the same patients, regardless of their language.
Hey, thank you for bringing that up. It was reminding me of I think a time when I was working before the department that I worked in really had like adequate language services via, I mean, I don't think, maybe had like Spanish interpreters during the daytime, like in person, but on overnight shifts, which I primarily work, not even having like anything sort of adequate in place. And the case that always sticks out in my mind was like 3 a.m, you know, a patient is brought over from a local skilled nursing facility. And I'm told that there's, you know, there, first of all, isn't any family around to even provide any sort of information about the patient to me. But the patient after a stroke was sort of globally mute, but only understood Japanese, did not actually understand any English. And without access to Japanese interpretation, I mean, I grew up in a household where some Japanese was spoken and I studied the language for a couple of years in college. But, you know, the one day that we talked about health terms, I think I remember the words for pain and for cancer, and that was about it. And so, you know, it was, you know, I thought about in the moment, like how sort of challenging it was for me as a clinician to be able to get any information out of the patient with like the very limited Japanese that I speak, but also thinking about what this patient must be sort of experiencing in a place where they may not be able to even verbally communicate their needs, and they certainly don't understand anything that's being spoken to them. So that case kind of sticks out in my mind as like one that really hit home, like the importance of making sure that you have like not just you know, not just like some of our panelists mentioned before, not just having like someone who might be standing there that could potentially interpret or translate like a family member, like that's really not appropriate, but even, you know, having a service that can provide you with professional interpretation in multiple languages, you know, if you don't have access to native speakers who are qualified to do so. So yeah, I appreciate your response there. So you know, as native speakers, I would imagine in healthcare that you've probably been approached at least once by a colleague or somebody else to sort of help them out with a Spanish-speaking patient or Spanish-speaking family member. So if you're comfortable, I would love to, you know, if you've had that experience, I would love to hear, you know, what that was like for you as someone who's a native speaker, but also working in healthcare and knows the importance of language justice.
Yes, absolutely. In my case, I'm a medical student in my 4th year. I'm rotating. I usually, when I'm getting in the morning, they see someone is a Spanish speaker, they like automatically give it to me because they know that things are gonna flow in easier. If the nurse need help, if the resident need help. But also it makes a huge difference for the patient because as soon as I go to the room, I tell them, introduce myself, I ask him which language preference they have. And I tell them I speak Spanish. You could see there in their face how like, oh yes, this is like, oh good, this is something familiar. I will be able to like communicate with my doctor or my or my resident. I do it like almost every day. Especially here in New York area where I'm right now, we have many Latino population from all over South America, Dominican Republic, Mexico. It's like from all over. And even though we might have like a word or a few words that are, meaning is different, you're still able to like provide them with the reassurance that yes, I understand you, we're taking good care of you. And then I think obviously it's a win-win for everybody, right? We're able to deliver better healthcare. The patient feels more comfortable, even telling you more like personal detail about their history. Even the other day, I had a patient that it needed to be transferred. So their family member didn't know how to get to the new hospital. So I have to like, the nurse looked for me, like, can you please tell them the new address? So I had to write it down on a piece of paper. Look, you take this train, you get off here. This is the room where she's going. So that's the impact. It's not only to the patient, but also to their families.
Wow, that's an incredible story. I mean, it's amazing that you were there to be able to really go the, you know, like my inclination is to say the extra mile, but really just do the right thing for the patient. I think it's very easy in healthcare, and I think we've probably all witnessed this, where we see the corners that get cut when it's either, you know, like was mentioned before, like if you have to spend a few extra minutes like tracking down the iPad, or you know, having to find an in-person interpreter, and you know, just how easy it is for those of us, and I really include myself in this as someone who doesn't speak a second language fluently, you know, just how easy it is to sometimes just do what you can do to get by, and think that that's sort of adequate, and it really isn't. And when it comes to even, you know, communicating with family members, and really making sure that, you know, it's not just like a direct translation of English into another language, that it's, you know, making sure that there's a level of understanding, that there's context, there's cultural awareness, and you know, it's just so much more than just the spoken or the written word. So I'm, you know, thank you for being there for your patients and for your other staff. But I know that does probably, you know, it's an extra set of tasks for you, and in a time when, you know, you're a student and you're learning, and, you know, kind of honing your craft before you head off to residency. Thank you. Either of our other panelists have a story that they want to share? Otherwise, we can move on to other questions. I mean, there's sort of like related stuff that we can bring up, but I would love to. I love stories, and I think they're very impactful. So I would love to hear from you.
I'm always happy to interpret for people and to help translate and help facilitate, especially with Hispanic patients. You know, it's nice to be able to speak to them in their own language, and you know, getting that appreciation definitely is also rewarding. But it can be challenging as well, especially because a lot of times your colleagues will kind of be like, oh, can you like just do the HPI or do the, you know, and I'm just like, no, I'm here to like, what questions do you want me to translate? Like, do you have chest pain? Like, I'm not going to do the whole, like, I don't even know why they're here a lot of times. Like, I didn't get the background. I didn't get their triage. They're not my patient. And I have been in uncomfortable situations where it's like the patient is really angry at the physician or the nurse, and then I get asked to translate, and I'm just like, I don't know what's going on here. You two are very angry at each other, and I'm just trying to like understand what's happening. Or like already they've used the family member as a translator, and there's been some miscommunication. People are angry, and then they kind of throw you in the middle, and you're just like. So, I mean, I always love to translate, but I'm just like, give me a little bit of a heads up of why the patients. So now I know. I always ask, why are they here? Like, at least a chief complaint, so that I can kind of know what kind of questions need to be asked, because sometimes it can be very uncomfortable.
I started just picking up the patient myself. The reason why I do that is because we're just so busy, and I'm just like, I'm not gonna spend the time. I mean, it might sound bad, but I just feel like by the time I finish translating, I've already known the history, so I might as well just pick up the patient. So that's kind of what I've done. So I've also stopped translating for other people, because I feel like there is now this thing that people think that I have to do it. I'm not a translator. I'm attending, like I'm not here to translate for you. So I think that there is a little bit of an abuse there. So that's why I've also like, I won't do it for anyone that's not my patient, unless, you know, it's a dire situation. I'm not saying like, you know, I'm not gonna walk by somebody that's screaming Spanish and then I'm just gonna be like, well, no, I should like moving away. But I think that it is a slippery slope. I think it's funny because when I was applying for residency, I interviewed with a PD, I think it was in Florida. And we were talking about being Latino in medicine and how there's this like, you know, this, everybody wants you to see the Spanish speaking patient. And everybody expects you to see the Spanish speaking patient. And he was like, I used to get annoyed because I would have my name on all these patients and I didn't even know who they were, but just because they were Spanish speaking, like nobody wanted to take the time to take care of this patient. And he's like, so what if I'm not there? Like, what's gonna happen? Like, is the ED gonna like collapse? Like, I can't be here 24/7. So I think it's interesting because, you know, you want to do what's right, right? That's why we went into the field, but sometimes you have to like also be like, you have to learn to do that extra step. You have to learn to use the iPad or the phone. Like, it's okay that you might need translators. Like, I pick up patients as well. I don't only pick up Spanish speaking patients. Like, I pick up patients that speak Russian. We have a lot of Asian patients, you know, so, you know, I try to be like the person to set the example and not always pick up the Spanish speakers, just because I want people to also know how to use that system. Because because the only other person that speaks Spanish is leaving. I'm the only attending that speaks Spanish. And to hear the other one speak Spanish is also like not, I hate when they scream. Like, that's another, I don't know why people are so obsessed with screaming when they know like 1 or 2 words in Spanish. They just scream at people's face. But again, I digress.
Yeah.
But I think that it is important to kind of like make the system aware that this is needed, particularly in triage. Like, I've been trying to work to get like a iPad there because we recently had a case that was also another misstroke, that they were mistaken for I think she was complaining of a headache and she had neurological deficits, but they didn't check in triage. They didn't call it stroke because, you know, she just said she had a headache. And it happens multiple times. Like, the other day I caught, this is another, but patient was 30 something weeks pregnant, complaining of abdominal pain. And she was kind of small, but she's Spanish speaking, but nobody asked her anything else besides the abdominal pain, but she's like she should go to L&D, right? So, I mean, these are things that, as small as they are, they do have an effect on patients and patient outcome, and also on how patient satisfaction, right? We're so obsessed with satisfaction. I think this definitely has an effect. And I think that in order to truly say that we care about the patients, we have to offer these services. And doesn't even go, I think the other thing that I have a problem with, particularly language in the emergency department, is that like, I recently found out, for example, that if for certain forms or Prescani forms, they don't offer it if you don't speak Spanish, if you don't speak English. And then that has to do with justice, right? Like, we're not offering people a way of saying this happens or this is how they treated me. We're not even offering them that option. So I think there's clear discrimination there, but I think that just language is just one aspect of how discriminatory we are in medicine. I sidetracked a little bit.
That was great. I mean, you brought up so many important issues, and you're right. Like, it's language is really just one aspect of many ways in which we can discriminate against patients. You know, and it's something that, just with it, like you said on your presentation, like, it's not the patient's fault. You know, like, I certainly have, as you know, sitting on this language access task force in the past, looking at survey data from, you know, our providers about their thoughts on the current services that we offered. You know, was it easy to use? Were you able to find an iPad? Like, things like that. Like, what are your thoughts on this? Like, general comments that people come from, you know, that we would ask for people anonymously. And I mean, somebody said, you know, I think that actually the patients need to work on their English. And I remember I looked at that thing on SurveyMonkey, and I like took a screenshot and like circled it in red, and I sent it to the rest of our group, and I said, this is totally inappropriate. Obviously I don't know who wrote this, but if this is the mindset that people in a very powerful position as a physician in the ED when people are sometimes at their most vulnerable, this is really like unacceptable. And, you know, I wasn't totally satisfied with the response that I got, especially because we weren't able to give anyone specific feedback other than just speaking up in our department meetings and being like, hey, like, I think we need to understand that, like, yes, this group is working and we're looking at metrics to see like how often we're actually using the interpreter services appropriately, but actually also, I think we all need to understand that, like, and this is in Southern California where we have a very large multilingual population. And even if you look at like projected census numbers, like we're going to continue to diversify and we're going to continue to have people in our communities and our hospitals that will need to be able to speak their preferred language. And I think the idea that, you know, because our official language is English, and, you know, like I'm sure people that like have traveled to like Europe or whatever realize that it's actually fairly easy to travel as somebody who speaks English, because a lot of people around the world do and can communicate in that way. That we really need to move away from this sort of English mindset or sort of English centrism when it comes to approaching patients, because it's, I mean, not only is it illegal to not, you know, to communicate with the patient in the language that they prefer to speak in, but it's also just unethical. And so I appreciate that you brought up all of those points, because I think that there are, I'm sure, you know, I'm sure people have countless stories of their own, just from their own experiences in the ED. I know I certainly have several. I think, you know, I think for anyone in our audience, like, especially if you're someone who's in a learning position, like, these are opportunities. It's really important to review cases, especially like the one presented at the beginning. If the patient bounces back and there's clearly a language related issue and something that maybe got missed because of inappropriate language interpretation during the index visit, I mean, this really is an opportunity to look at how you can do better. And if you feel empowered to speak up to your department administration, to your hospital administration about the adequacy or availability of language services, I mean, this is the way that we work towards preventing those cases where, like, for example, one of my cases from a previous job, I used to work in the Central Coast in California, where there's a large indigenous population that speaks Mixteco. And it's not really anything like Spanish. And really we did not have we didn't have any access to interpreters with that. So it ultimately came down to contacting another hospital nearby that actually had people that spoke Mixteco and could help with you know, doing the interpretation for the patient. But, you know, I think a question that very naturally comes up, I think, when we're talking about language is like, well, what do you do if it's the middle of the night and you don't have anyone that can interpret for you? It's like, well, I mean, I'm not here to advocate for just cutting corners. I'm certainly not, you know, there may be no good answer to a question like that, but I would say look at it as an opportunity to do better so that that doesn't happen again. It's very easy for me to say, I'm an attending physician, but I think, you know, residents and students should feel just as empowered to speak up, especially if you're someone that does come from, you know, a background where you spoke a language other than English growing up. Because I think your perspective is better than the rest of ours, for sure, and more important.
So at the point of day, like nowadays, it's not the Stone Age. We all have iPhones. We all have internet in our hospitals for the most part. There's multiple like online Google Translate that, you know, sometimes for different dialects, I understand it's really hard. And I've definitely been on that like ours is just a phone number that you call and a service that is provided. And I've definitely been on hold in that for like 20-30 minutes trying to get somebody. And like, again, I'm not advocating at all for using family members. Sometimes it is what you have to do because it's what's available. But there's alternatives nowadays, like a lot of alternatives.
I'm not against, I mean, I understand, like I had a situation where a patient didn't want to use a translator and wanted to use the family. I think there was a culture aspect to it. But what I am against is like using children. I actually had like a colleague, I think, I'm kind of known for, I'm very vocal, let's just leave it that way. I saw patients, I saw someone using a child as a translator, and I kind of like said something. I don't, being someone that actually was the child that translated, I think it's a lot to put on the child, and people just don't understand that. Like, I was put in situations as a child personally that I should have never been placed in, because I feel like I did have to mature, not to get too personal, but I did have to mature much quicker to understand what was going on. And also the complexity, right, of the fact that I had to like know medical problems of my family members because I translated for everyone. That again, perhaps I wasn't mature enough to understand. And I think that's something that people don't grasp, is that the effect that it has on the family, not only on the patient, like there's a family dynamic that occurs. So I just remember the case and I was like, no, it's not happening. So
I agree. I mean, in medical school, they teach us like learn effective communication. And I think the first step in effective communication is one, you have to speak the same language or have somebody to translate so that you could be able to communicate in the same language. But then the other thing is medical language is a completely different language. I remember going to medical school and learning all these new terms that I had maybe heard of, but I didn't know what they meant. And like, it's, you know, it's the whole, you don't tell a patient you're having a STEMI or a myocardial infarct, you tell them they're having a heart attack, because you need to be able to communicate in a way that the patient understands you. So it goes the same way with children. Like they don't know the terms. Like in a lot of times it's not even children. It's like your other person might not be in the medical field and they're not going to understand the terms and they're not going to be able to translate. So I think the whole point of this, like all of this, is that so much can be lost in translation when you don't use the proper means to actually have someone translate for you, like an appropriate adult that understands both languages.
And to jump off of that
it's-
as well, like there's a need to, I'm sorry.
Oh no, I was just saying that it's very important that you brought that point, Dr. Simish, is because I was reading about the difference between translation and interpretation, and one thing that got my attention is like they reinforce and reinforce over again, and is that when you are interpreting, you have to have like a knowledge of what you're interpreting. So you need to have like a basic of knowledge. So a kid doesn't know medical terms, right? Not even adult person, maybe yes, might know some, but not all. So someone that translate need to have a extensive knowledge of the subject matter. To and in addition to that, it's like also there are cultural and linguistic understanding between the person and the person that is interpreting. So I think that's the great point.
I think it's also important to understand that even though you speak Spanish, and I think Dr. Simic kind of brought it up as well, you might not speak medical Spanish. So I know a lot of people that do speak Spanish and they can defend themselves, you know, here and there with a little conversation. But for example, when it comes to talking about like the gallbladder, they don't even know what the organ is called in Spanish. So at that point, like that person really also shouldn't be serving as an interpreter, because you don't know how to explain what's going on to the patient. So I think that's an important point. And to jump off of that, just because I want like talking something else that Dr. Summers said that I wanted to talk about is that we do have a lot of resources available. I think one thing that kind of blew everybody's mind is that, for example, like writing discharge instructions, right? There was a case where that we actually was brought in our like PI that some patients got the instructions in English and they were not English speaking. They spoke another language. And I'm like, you know, you just could have put it in Google Translate, and Google Translate would have done it for you in English, and you could have put it in their language and just copied and pasted into the discharge summary. So I think that little things like that, like we forget, like giving something in English when they don't speak English with instructions is not really helpful. You might as well just not give them anything because they can't even read it. So I think that's also important.
I think that's a super important point because I think there's been multiple studies that show that people who don't speak English as their primary language or speak limited English are less likely to advocate for themselves by asking questions or asking for clarifications of discharge instructions or speaking up to doctors. And I think it's very understood when you're working in the ED that calling the interpreter can be an additional step, but a lot of people will be willing to do it to get the HPI and do the physical exam, but then they don't want to do it for the discharge. And that's such a huge disservice. When I was working with residents, I would always tell them, like, if you're calling the interpreter to get all the information, you have to discharge them with the interpreter. Like, you can't skip that step. I know it's annoying to call again and have to wait and all that, but so much information can be lost in the discharge. You know, just telling them, like, just saying like, okay, like everything's okay is not like, that's not an appropriate discharge. You have to explain to them, you have to especially explain things like what medications they're going to take, the side effects of the medications. You know, like I always give as an example, like in Spanish, when you put, like, if you write in English, like once a day, like for a medication in Spanish, that can translate to once, which is 11. And I once had a patient who, instead of taking the pill once a day, he was taking it 11 times a day. So again, these things are like, it's not just in your HPI, it's really important in the discharge to actually be able to speak in their, like, to communicate with them in the language of their choice, because then it's better for them because then they're able to ask questions. They're not going to ask, if you're just talking to them in English and they speak, I don't know, Bengali, and you're just like, good, like, bye, everything's okay, because everyone kind of understands okay. They're not going to ask you any questions.
I have like personal story about that, and it's, yeah, good thing it was nothing like major, but I went back to home for the holidays, and like a few days ago, my dad went to the ED because he was in construction and he got cut, so he got some stitches. It was like day 12. I'm like, Dad, when are you going back to get the stitches removed? And he's like, oh, they never told me to go back. So it's like, can you show me the discharge papers? And when I get the discharge papers, they're in English. And first, it's in English. Second, they didn't have the instructions to come back. I was like, okay, I will, it's more than 10 days, I will take them away. But it's just, it was a stitches. It's something simple, you know, no medications or nothing. But that's a very like example right there.
Thank you all for sharing those. I mean, and it just kind of like, as I'm sitting here listening, like, I think one thing that I would just want to share with our audience members, especially those like me who are primarily English speaking and not bilingual, is that, you know, what I'm hearing from our panelists is people who have experienced, you know, what can happen or what can go wrong when there is a language issue. You know, that to me, like, I see the advocacy that grows out of that. And so it's really important that we have folks like our panelists here getting into medical school and going to residency and becoming attending physicians who now have that sort of, you know, just lived experience of seeing where things can go wrong, and also, you know, having to play the role of the family member interpreting for your parent or somebody else in your family. Like, so I think just keep that in mind, because we're not just talking about, you know, speaking another language fluently. We're also talking about, you know, folks that are drawing from experiences that they themselves have had. And I think I think it's a privilege for people like me who didn't have that. You know, naturally I'm going to have a blind spot there. So just something to sort of think about anytime you encounter a patient who requires a different language be used to communicate with them, because not only are there a lot of places where you could mess up inadvertently and unintentionally, but you know, just how important it is for, like, you know, like we're hearing Elaine talk about being the only native Spanish speaker in her department, and in a place where there's a large body of Spanish speaking patients. Like, that really doesn't make sense. That doesn't fit. Like, that's not really, to me, as someone who doesn't, I don't know what that department's like, but it doesn't really seem to reflect the community that it serves. And I can certainly vouch for that in all the hospitals I've worked, where, you know, very few physicians will speak the language of the community that they're working to care for. So, you know, if there's anything that folks can take out of this discussion in terms of advocacy, I think it really is like, you know, how do we work towards getting more native speakers into the medical profession, whatever it is, you know, whether it's nursing or, you know, going to medical school or becoming a social worker, physical therapist, like whatever. I mean, we really need that. That's why we really talk about diversity. It's not just about having, you know, a diverse set of faces and people of different races and ethnic backgrounds. It's really making sure that we have the people who can really do right by the patients. And that's not to say that those of us who, you know, may not have the same language skills aren't able to do that, but we can actually do something. We can actually advocate and really stand alongside our colleagues who are working and know the importance of working towards those goals. So I appreciate that that you all shared that. I wanted to, just in the last couple of minutes that we have, we've talked a little bit, we sort of brought up medical Spanish a little bit and how, you know, it's different than maybe it's certainly different than the language that you grew up with in your home. But it's also going to be different when it comes to, like, yeah, you can't just literally translate like things like hypertension. Like, you're going to have to use like appropriate language when you're talking to a patient who may not understand medical terms, which I would imagine the vast majority of any of our patients don't. So what's the role of medical Spanish? You know, it's certainly gained a lot of popularity. I remember taking an informal medical Spanish course when I was in medical school, and it was helpful to learn words, but being able to put it into use was a completely different story. But I would love to hear from you. Like, what are your thoughts on medical Spanish? Is it something that should be like standardized, given that we don't have enough native speakers currently in our healthcare system? Like, where do you feel like that fits in when it comes to patient care?
Maybe it depends, right? Because when we're translating, there is not only the language component, right? There is a culture component, the educational level of both way, like, of the patient, and sometimes I ask the patient, ¿tienes hipertensión, like hypertension? And they are no. And then I ask, oh, ¿tienes la presión alta? And they are yes. So yeah, you have like high blood pressure, but you don't have hypertension. So it's not only, maybe you know the medical terminology, but the patient doesn't know the medical terminology. So that's another barrier added to it. But at the end, any additional help that will benefit the patient is, I believe, is welcome. As mentioned earlier, we had trying to teach like medical Spanish, and the way we were this was my project. Not only my project. We have Dr. Martinez. He's initiated, and the idea was to, like, okay, we are not teaching medical Spanish should you have a fluid conversation, because maybe you don't have the time to learn it, or any other reasons. So what is in the same way that you learn English, you know, or no, I'm sorry, that you learn like medicine is like a new language, right? So you learn like medical Spanish. You know, you learn a phrase, so that will, or you memorize a sentence, so you get the most information out of the patient. That doesn't mean is the most accurate. It doesn't, but at least you can have it like an idea what's going on, right? Or like you can come up with some like differentials. But at the end, if it's gonna help, I believe, the delivery of the healthcare. Anything helps, even learning a word. Yeah.
I think it's great that medical schools particularly are doing medical Spanish in when you're still a medical student. I do think that residencies should focus on whatever large community they have. Like, obviously Spanish is the second most common spoken language, second only to English in the US. But if you have a community where you have a large population that's from Vietnam, maybe then it's, focus on speaking Vietnamese, or if you have a large, Arabic speaking population, focus on that. It doesn't necessarily have to be Spanish. Like we are from, we grew up and trained in New York, where there is a large community that speaks Spanish, but there's also a large community that speaks Haitian, that speaks French, that speaks Bengali. So I think it's important to, whatever the population in your community, where you're in the hospital, whatever community you have near your hospital, I think it's really important to kind of have whatever language that is, kind of have a class or something for residencies, for residents and for attendings as well. It doesn't just need to stop in residency.
Yeah, I agree. We have like a lot of Albanian speakers and Italian speakers, and I want to take out Italian during my free time when I find it. But I think that there's a need to kind of understand your surroundings and your community. And I think language is tied into culture, right? So I think that not only should medical schools and also residencies offer education about language awareness, but also like culture awareness. There are certain things that beyond, I know everyone knows about certain cultures, men can examine women and things like that, but even their descriptions for symptoms is important. So for example, speaking more to Albanians, they focus on like feeling cold in their feet, something like that. So to that, that to them, they have fever, things like that. So things that you can pick up that are going to help you decipher what exactly is going on with the patient is important. And I think that kind of goes hands in hand with the language, because it's communicating, right? It's effective communication.
Great, thank you so much. I feel like I could sit here and just talk about this for so many more hours. Unfortunately, we're running low on time, but I want to just extend a huge thank you to our panelists for contributing to such a great discussion tonight. For our audience members, certainly you know how to get in touch with me. If you ever want to talk more about this issue or anything else that's sort of through the JEDI lens, we always want to hear from people that are watching these webinars. But if you've gotten some inspiration out of today, yeah, look at your own institution or your own school and see, what's it like there? What is, how effectively are healthcare workers communicating with patients when it comes to language? And I think there's something that we can all do about that. So, I've certainly done some things on my end. So if anyone ever wants to talk about ideas, definitely send me an email. And certainly keep in touch with the JEDI group when we have our meetings every month. These are things that are absolutely critical that we talk about regularly in the spirit of really achieving health equity for our patients, and also having I think a supportive and inclusive space for physicians, medical students, residents who come from different backgrounds. So thank you everyone so much for joining us. I do have a couple of announcements. One, I wanted to share, and I think I should be able to get this on the website as well, but I'll share the link in the chat. This is actually Amado shared this resource with me. This is a little bit of a YouTube medical Spanish course that kind of goes through different patient presentations. So it is at least a way, just in the spirit of free online resources to, explore medical Spanish, get your feet wet if you haven't really looked at it yet. Obviously, as our panelists have said very correctly, is that this is really just a it's a supplement to adequate communication with patients. It should not replace using a native speaker, a medical interpreter, someone who's not the family member and whatnot. But I think empowering yourself with being able to learn some words and phrases is always a good thing, so that you kind of know what's going on, but make sure you always just do the right thing for the patient. I did also want to make an announcement about a healthcare disparities rotation that is happening at Carolinas Medical Center. There is a link here, and again, I'll try to get this posted on the website. So Dr. Cortland Brown, who's our section's chair-elect, is the clerkship director for this course, which is an externship for MS4s who are looking for a way to actually, focus on health disparities in the ED. Looks like a stipend is offered. There's a SLO offered as part of this sort of rotation package. So the link is there for more information. Cortland has also offered to, be available for questions that arise. So just let me know if I can do anything to help facilitate that. Like I said, I'll try to get those links posted on our website. Thank you again to our panelists for being here. I really think this is a powerful discussion, and that concludes our session tonight. So thank you everyone for joining us, and have a wonderful evening. Okay, bye.
Thank you.